Are we live?
Yes, doctor, we are live now.
Yeah. Very good evening to one and all of you from the I Foundation group of hospitals. This is a very, very warm welcome to our Catateach video competition. And this is an event where I Foundation has teamed up with the Young Ophthalmological Society and the very famous popular YOSI group. Actually, just when the thought conceptualized in our minds that why don't we do a webinar or two with you all, I was just amazed at the kind of energy and enthusiasm which was shown by Dr. Divakant or Nilesh or Sonal and everybody, Aarti, everybody. And Lippy was so integral along with Sonal to see that this whole program, this competitive thing was ensured, which would get a lot of the young ophthalmologists participating and showcasing your talent. So, over the last few years, I've been seeing you all in different podiums and different programs, and I've been so impressed with your cohesiveness, your ambition, your niceness, and everything. The whole combination of attributes which you all seem to have, all of you in your team. And I really wish you all such a super, brilliant future, be it on your personal front or in the academic front. I'm sure you all are right up there. But I hope this consistency keeps going on along with everything nice happening to you on your personal front. And I hope this next 2 hours of Catateach video competition is the most interesting and challenging event for all of you. And we have a great set of expert panel and judges and moderators, with participants both from iFoundation, the group of hospitals, and the YOSI group. And I hand it over to Dr. Lippy to make the introductions. On to you, Dr. Lippy.
Thank you so much, ma'am, from the entire YOSI team to give us this opportunity from the entire governing council and executive members. So we have expert panelists for today's session. Dr. Murlidhar R. Sir, he's a senior consultant, cataract, glaucoma, pediatrics, strabismus and neuro-ophthalmology from Eye Foundation, Coimbatore. Dr. A. Nagesh Sir, senior consultant in cataract and refractive services at RIK, Eye Foundation, Bangalore. Dr. Nilesh Kumar, he is the director and consultant at Madhvi Nethralaya, Bihar, and he is also the general secretary of YOSI. And Dr. Bhavya Gokani, he's a consultant cataract, refractive and glaucoma at ASG Eye Hospital, Ahmedabad, and he is currently an executive member of YOSI. So we have an incredible judges panel with us, Dr. Srisha Kumar Sir. He is an associate medical director and senior consultant, Cornea, Refractive and Cataract Services, the Eye Foundation, Coimbatore. Dr. Vidya N. Ma'am, she's a senior consultant, cataract, orbit and oculoplasty from the Eye Foundation, Coimbatore. Dr. Sonal Kalia ma'am, who has been the backbone of this session. She's an associate professor at SMS Jaipur, and she is an immediate past president of YOSI, immediate past executive member of Jaipur Ophthalmological Society and Rajasthan Ophthalmological Society as well. Dr. Aarti Heda ma'am, she is a consultant based in Pune, specialized in cataract, glaucoma, cornea and refractive surgery. She is an associate editor of the Global Journal of Cataract Surgery and Research in Ophthalmology and has been an active member of YOSI. So, Dr. Chitra Ramamurthy ma'am, she needs no introduction. Ma'am is the medical director and senior consultant, cataract, glaucoma and refractive services from the Eye Foundation group of hospitals. Ma'am has been the chairperson of Academic Research Committee, AIOS, from 2020 to 2023. Dr. Tamilarasi S. Ma'am, she's a senior consultant, cataract and IOL services. She's also a FACO trainer for FACO Shala, the Eye Foundation, Coimbatore. Myself, Dr. Lippy Mittal, consultant at Center for Sight Palwal and executive member YOSI, and Dr. Anujit Paul, consultant cataract and vitreoretina surgeon, BBI Foundation, Kolkata. We will be the moderators of today's session. So before we begin, I would like to remind all of you that we have 2 audience choice winners and we are going to have an audience poll towards the end of this session. So I request everyone who wants to cast their vote for their favorite contestant or favorite video, please join us on Zoom. So let us begin. Over to you, ma'am.
Yeah. So we shall start off straight away with our first speaker, Dr. Aditya Varman, who's the medical director of the Uma Eye Clinic, Chennai, a very famous known hospital over the years, and he's the executive member of the YOSI Society of India. So Aditya, on to you. Let's see your challenging video.
Sure, ma'am. Thank you for that introduction. So I'll just share my screen now.
I request all the judges to keep scoring every participant. Thank you.
So just give me a second here. Just open the video and share again. Just give me a minute. Yeah.
You have not shared. Yeah. Yes.
Yeah. Lippy, I'm just going to play the video. In case the audio is not coming, just let me know.
Okay.
Okay. We have an interesting case here today. This is a patient who's got a cataract with a very shallow chamber, 360 degrees of synechium, and obviously a very small pupil. So to approach this case, the first thing we need to do is to expand the pupil. There could be multiple approaches to this. Pupillary expansion devices are definitely an option here. But what I attempt to do here is to just find a space and dissect the pupillary membrane away from the lens capsule. So I'm now getting under the iris and trying to dissect the membrane away from the lens capsule so that we may now attempt to peel the membrane away from the pupil. One must be gentle in this approach, as pulling too hard could cause an iridodialysis. I will now proceed to stretch the pupil to achieve more dilation using a Kugel hook and a Y instrument. One can do this in 2 to 3 quadrants to ensure that the pupil is evenly dilated, so we can safely perform a good capsular exit. With this, we've now achieved maybe about 5 mm of dilation. Achieving a well-centered and a large rhexis is a non-negotiable step here, as it is very vital to maneuver this cataract. So as you see, I'm just taking the time to ensure that my rhexis is at least the size of the pupil. I'm also attempting to go under the margin of the pupil and get a nice round center 5 mm rhexis. What's important here is to always keep the capsule flat so that one gets very good control over the size of the rhexis and centration as well. Getting a good hydrodissection here is also important, as this looks like a soft cataract, and making it mobile will aid in its removal. We now proceed to the phaco. The current phaco settings are at vacuum at 550, flow rate at 40, and power at 40%. I start by making a small trench to facilitate in my phaco-chop maneuver, and using the high vacuum settings, I'm able to split the nucleus into 2 even halves. Getting even half like this will make the rotation and mobility even easier. As you can see, it's a very soft cataract. I'm hardly using any phaco power here, rather just using vacuum and mechanical division in order to get the nuclear pieces out of the capsular bag and finish the phaco very safely. One must keep in mind that in the small pupil cases, the pupil will tend to get aspirated in the phaco tip if the surgeon is not very aware of the fluidics that's happening inside the chamber. So as the case goes on, I'm continuously monitoring the size of the pupil. And as I am wolfing down these nuclear pieces, I slowly bring down my phaco parameters so to be careful not to accidentally grab the iris at any part of the surgery. So the nuclear removal is now done. We shall now proceed to INA. As you see here, I still have a very thick epinuclear sheet left behind, which might be challenging in a small pupil case like this. So I'm just taking my time here, trying to make the epinuclear sheet loose in all quadrants, which will then aid its removal very easily. As you see, because I'm using a very high vacuum of 650, Even though the epinuclear sheath was very thick, it's easily being removed with an IUL. So finally, we now proceed to IOL insertion. Here, I'm implanting a trifocal IOL, which is a toric version, into the capsular bag. Hope this video was enjoyable. Thanks for watching.
Yes, that was a wonderful video, Aditya. So
Thank you.
actually, Dr. Murlidhar, you've not joined yet? See, Murli was in a busy OPD. He will come by this next turn. So now, Nilesh, can I take that question with you instead? Okay.
Yes, Mr.
Yeah. See, that was a wonderful video which he showed. So, it was a typical case where the pupillary membrane removal and then stretch works, where the stretching a pupil would never work in an IFS. But supposing the pupil had failed with the lysis of posterior sinus and the stretch, what do you think in this kind of case would have been the pupil dilating device which you would have used?
Ma'am, for me, the go-to device is BHEX. If there is in IFIS, I have used B-Octa as well. B-Octa is the new device that comes from Subin
Yeah.
sir only, and it is giving a dilatation of 8 mm. So it is not more about dilatation, but what it does is it brings the pupil below the incision margin, so the prolapse prevents. So if it is in case of IFIS, I would prefer to go with B-Octa. If it is not IFIS, BHEX 2.0 will be good. And I don't prefer to use iris hooks because it tends and then the AC becomes very shallow. And in my hands, I tend to damage the iris during that process.
Uh-huh. Okay. The other thought which came to my mind, which I thought I could ask the Sonal. Sonal, he did everything, the hydro, the repeat hydro for the epinucleus, everything he did. But in a shallow anterior chamber and in a hypro, would there be what would be your extra measures which you would consider doing, whether pre-op or intra-op?
Ma'am, I think one thing which is important is to keep the bottle height in check. If it is too high, then it can cause problems. And if it is again kept at a medium level, it would be better. Second thing that I was wondering, I wanted to ask Dr. Aditya actually was that what was the post-operative size of the pupil? Because this pupil will not react like a normal pupil. So then you've put in a trifocal IOL. So what was the post-operative period like?
Yeah, it was around 3.5 to 4 mm. Yeah, so it was static. Yeah, like you said, it doesn't react, but the vision was good. The patient is reading 6.6 and 6 in both eyes, but the challenge we faced for the next 3 to 4 months after this was consistent iritis. I think in a case like this, it's always expected, regardless of what device you use for pupil expansion, because you are still manipulating the sphincter. So that is the challenge, but it's
Okay.
kind of fixed at around 3.5 to 4 mm.
Yeah.
Can I come in?
Yeah.
Yes,
Dr.
sir.
Chitra? Yeah. Yeah, this is actually a complicated cataract. Do you suggest any multifocal or multifocal toric IOL in such cases? Like you can expect post-operative uveitis or iritis and subsequent development of post-operative CME and all. The chances are very high.
Yeah.
Of course, like placing a lens is not a difficult job, but is it advisable?
Yeah. Typically not, sir. Yeah, you're right. But the patient was very motivated, and the extra care that we took is we put her on long-term steroids and NSAIDs. So we managed the inflammation that way.
Yeah. Very well. Very good. Of course, if it were not a case of uveitis, just a shallow AC and a hypro, I would like to prevent positive vitreous pressure. And then in those cases alone, I would have definitely added a pre-op glycerol or a Dimox, or if it is really too shallow and a smaller eye, then I would even think of adding a mannitol if the cardiovascular condition allows. But in this case, this is all that was needed, as Sonal said, just keeping the parameters lower and keeping away from the pupillary margin, keeping your phaco in the center is fine. So I think we go on to the next Dr. Arvind and Lipi. Why don't you take over?
Yes, so our next speaker is Dr. Arvind Krishna VP. He's a resident at Arvind Eye Hospital, Madurai. Over to you, Dr. Arvind. You can share your screen. He will be showing us the importance of proper orientation and angulation of instruments. Over to you.
Yes, ma'am. I'm just trying to. Ma'am, I think it's asking me to quit and reopen. Can I do that?
Yeah, do that. Oh, you,
Okay. I'm not one second.
should we wait or should we go on to the third speaker?
I think,
And give
ma'am, we
him-
should move on
give
to
him
the
a-
third speaker. We can have
Yeah.
it next, yeah.
We can have him next now. So the next speaker is Dr. Rohit Rao. Rohit, you're ready, no? So
Yes,
Tamil,
ma'am.
why don't you introduce him?
Next, I invite Dr. Rohit Rao. He is a senior consultant, cataract and oculoplasty from Sri Ganesh Vinayak Eye Hospital, Raipur. Over to you, Dr. Rohit.
Good evening. I'll just share my screen.
Yeah.
Yeah, sorry, I'll press it next. Thank you.
Yeah.
Dr. Rohit, your video
voice?
and audio is not there.
Voice is not there.
No.
Voice is not there.
So before sharing your screen, there's a option of sharing your audio as well. So click on that also.
And when after Rohit,
You give me a minute. I'll just check out how to do that.
what is happening? You click it open, you click it, then you will find that symbol.
Rohit, there's a checkbox on the bottom of the screen which says share audio when you are sharing. Just click the checkbox which says share audio, system audio.
Or else you talk along with it.
Can the next speaker present? I'll just log in with a different computer.
Okay.
Ma'am, I am actually ready, I think.
Okay, Arvind, take on. So Arvind, Lippy, you will ensure that Nilesh and Shrisha are involved. Okay, done. Okay, come in, Arvind. You share your video. I think
Yes.
all of you speakers should have shared your video beforehand and
I think we've already them if they might have it. I'm not sure. Ma'am, is my screen visible?
Yes.
Yes.
Yeah. Good evening, everyone. I'm Dr. Aravind. I'm a final year PG from Aravind Hospital, Madurai. So the video I'm about to show was recorded during my first year of postgraduate, during my 5th case. So it's going to be a relatively common complication, but the way it occurred is quite uncommon. So I made it as an educational video for me and my fellow residents, and I hope you enjoy it as well. Please let me know if the audio is not. I'm going to start it now. In small incision cataract surgery, precision at every step is critical. In this case, we examine how an error in instrument angulation led to an unexpected complication. The resident begins with a peritomy to expose the sclera. Next, the surgeon proceeds to make the scleral groove and then constructs a sclerocorneal tunnel. A side port is then made. Watch carefully as adrenaline is injected through the side port. Due to improper angulation of the cannula, its tip accidentally pierces the anterior lens capsule. Unaware of the breach, The surgeon then proceeds to inject trypan blue dye along the same tract. The dye enters the lens substance instead of the anterior chamber. But unfortunately, the training resident, without suspecting anything wrong, proceeds with the case. After keratome entry, capsulorhexis is attempted. However, during this step, something unexpected happens. The moment the capsule is touched, it suddenly gives way and the rhexis quickly runs off to both sides. The surgeon immediately senses that a complication has occurred. Let's take a closer look at what exactly led to this unexpected situation. While taking the adrenaline cannula inside, due to improper angulation, the surgeon accidentally perforates the anterior capsule and proceeds to inject adrenaline into the lens. Trypan blue dye was accidentally injected along the same tract. The fluids had entered into the lens matter, increasing its volume and internal pressure. This resulted in an intumescence that was purely iatrogenic in nature. Upon initiating the capsulorhexis, the built-up pressure forced the tear to extend outward, resulting in the Argentinian flag sign. Once the complication was recognized, the case was then handed over to a senior surgeon. The rhexis was modified using Van Ness scissors in such a way that the nucleus could be gently delivered out with careful maneuvers. After a thorough cortex wash, a 3-piece IOL was placed in the sulcus. To avoid such complications, ensuring good visibility at all times is important. We should always check the orientation of the instruments. A gentle and controlled entry into the anterior chamber is very important. Here is another case done by a senior surgeon where unintentionally there occurs a breach in the lens capsule while injecting saline. But here, the surgeon quickly recognizes the breach the moment it occurs. He proceeds to begin the capsulorhexis by grasping the part of the capsule that has already been torn. He continues the rhexis by including the breached capsular flap so that it does not run off. As a result, a uniform rhexis is completed in a controlled manner. This case serves as an example that complications can happen at any time during a surgery. However, such complications are also an inevitable part of the surgical learning curve. Every mistake is a lesson and every case a teacher.
So thank you, Dr. Arvind. I think along with the importance of angulation, it also taught us that, recording surgeries is also very important. Unless you record your cases, you will never know what went wrong. So I would like to ask Dr. Shrisha, sir, so what are your tips and pearls or comments about this video?
It's a nice educational video, and it can happen to anybody, like who is starting their surgical career. Here, it has happened while injecting some Blu-rays into the antechamber, and so this can happen even with the blunt keratome. Like when you are making an entry into the antechamber, suddenly if you are using a blunt keratome, it can, with the jerk, it can hit the anterior capsule, and you may end up having an anterior capsular tear. Or you maybe while hydrating the side ports at the end of the surgery, you might split the posterior lamella of the cornea into two, or you can create a Descemet's membrane detachment. These are all some of the complications that can happen in the early stage of your surgical career. So nice demonstration of the complication, and it's been nicely handled.
Yes, sir. Thank you, sir.
Thank you,
Yeah.
sir.
Usually, as residents, we are focusing on the tunnel a lot, but we tend to be a little complacent while making the side port. So this was a very good learning for me and my colleagues, sir.
Yeah.
Also, so sometimes it is not possible to record your cases when you're in periphery or when you don't have your recording devices. So, any tips and suggestions for that? Because inadvertently, young ophthalmologist thinks that they are not doing the steps right, instead of thinking that, you know, the angulation is wrong. So, how to know in such cases when you don't see your video, when you don't record your videos? Dr. Nilesh, sir?
Yeah, most of the centers have a live display that is there. There is no center, even remote center now have a live display attached to your microscope. So what you can do is you can carry a portable recording device. It's very easily available. What the gamers use for live streaming in YouTube. So you can just pull out the HDMI from the TV, and you just attach that in between, and you just attach a STD or a hard disk in between. So it won't give you segmented file like for separate for each of the surgery. What it will do is a 3 hour recording, and then you go back and then you just cut it and do it. So if you have a live display, this will work. If you don't have a live display at all, then it becomes very difficult, at least for the surgeries to be recorded. In OPD, at least you can do some smartphone photography, but for surgeries, it becomes very difficult.
The other thing I felt was he made that side port entry with the keratome. Ideally, going further ahead in our career, it is to have very calibrated side port entries. So maybe an MVR blade would be more ideal because the opening is very small. And of course, all of us in our surgical training should start learning to make our X's not from the main incision through the side port itself. That way the anterior chamber is constantly formed and the valvular incision of the SICS is also closed. So there's going to be no egress. If you go to the main port, you have to be very careful that you don't press on the posterior lip and have the viscoelastic gushing out. That time also, you could end up with a Argentinian flank cell. This was, of course, not an intermittent cataract, as Arvind explained, but a side port, calibrated side port entry would allow a better management.
Yes, yes, ma'am. I have shifted to side port Rexis much, after a while, nowadays, ma'am.
I know.
So,
Lipi, apparently, Rohit is yet to join. So maybe we go on to our fourth.
Ma'am, he's ready now, ma'am.
He's ready? Okay.
Yeah.
My audio is audible now?
No, we heard you only.
Okay. I will speak if that is
Yeah,
okay.
go ahead. Go ahead.
Good evening, everybody. We will revolutionize the phacoemulsification training with this 3D printed model. This is the designing opportunity. We have done some older prototypes with foam. Here you can see the nucleus, the quadrant, and then the IOL implantation. So this way we used the idea. Then we used free CAD software which were uploaded to NIH website. These are the large scale model which can help us in orientation to surgery and video auditing. Whenever we are teaching, I face multiple times difficulty to understand what my point is. So here we have three pieces, which is the posterior capsule, nucleus, and the rhexis. Now we proceed with the nucleus management. So first we'll start with the divide and conquer. In this divide and conquer, first we will start with the initial trench. The initial trench is slowly from the proximal edge to the distal edge. And then we'll rotate and proceed with the second trench. Now the phaco and the chopper are used to separate all the quadrants. Here we engage and pull the quadrant and chop. Now we are proceeding to stop and chop. First we'll make the initial trench, then slowly we will divide the quadrants into two pieces. Then we'll proceed with nucleus rotation And now we are going to the periphery, and after we have engaged and cut it. Now we will proceeding to direct chop. Here again we will bury the phaco probe, and then we'll use the chopper to engage and separate. Here we are displaying the vertical chop technique. The smaller quadrants are again now one by one they are removed with minimal burst of energy. Now comes the IA. Here we have used some cotton which represents the cortex. We are using a coaxial probe to simply aspirate in a radial manner. Now going ahead with the IOL implantation. First, the leading haptic has to go inside the bag, and then we slightly pull the haptic at optic junction to the center and then dip it inside. This way you can put the IOL inside. So whenever you have a problem, the perfect solution could be 3D printed. All the models are accessible through NIH website, and you can go ahead and download it from there and print it. Thank you.
Dr. Rohit, it was a very interesting video. I think for training, we are always used to animal eye or a cadaver eye. And have you compared a trainee's performance using an animal eye versus a 3D model?
Yes, I have compared with goat's eye. And goat's eye, we have to be having with the eyepiece, and with under the microscope only we can teach. So this model has a best part is that you can hold it like this. So physical model of a quadrant, and I can tell like this. You can go with the phaco probe and then chop where to put the chopper. All the models, all the things can be displayed. So that is the novelty of this. This model. These are all large scale models. So you don't need a setup of a microscope. You can simply with the video playing, we can discuss. The main benefit is while video auditing, whenever you are discussing our video training videos, at that point of time, I feel it is difficult for them to understand where to put the phaco probe exactly at which depth, and whether our chopper is going nicely under the at the periphery or not. Those finer details are difficult to understand sometimes in initial days. Slowly with experience they get it, but that process will reduce, the time span will reduce.
Okay, how does this going to compare with the tissue field tearing effect, all those things? Since
Yes,
it's a large
that is a limitation. Though in initial days we can orient the first year residents to how the steps of the surgery goes, and only we can tell whether they are going in proper place or not. Those things we can tell, but the tissue feel and the micro instrument handling, all those things we need to practice in wet lab.
Okay. What do you think future modifications or improvements can be done to this technique? Or
I want to develop this for other steps also, because the rexis is already pre-cut. So most of the point what we can display and discuss is IOL implantation, cortex wash, and nucleus management. Maybe if something we can do for incision placement or other vectors, all those things, if we can do some kind of model. I'm also working on a model of a nose to learn how to do endoscopy. So there are some applications we can work it out.
Kamai, could you ask anything to Nagesh and Aarti also?
I want to add Dr. John had played a very important role in this model preparation. He was the one who designed everything.
Yeah.
any inputs from Dr. Aarti or
Study. You should consider a study comparing this with the simulators in the early cases. There are a lot of simulators. So if you will do a head-to-head comparison, then the reality will come out in terms of how much of improvement it brings in the surgical arena. Exactly.
Yes.
Nagesh, are you there?
Yes, ma'am. Yes, ma'am.
Namrata, Tamil, can you ask?
Dr. Nagesh, do you want to add anything to this, or since it's yeah?
It's just putting your imagination into a practical way, but doesn't give any great benefits actually. The wet labs are the ones which can give a real experience, even if it's a goat's eye or whatever it is. So I think that should be the priority. Yes, definitely you can go ahead and improvise on these things, and if you can create a artificial chamber and create some artificial machines and learn, it will be added advantage.
Yes, sir.
Can I comment,
Yes.
Dr. Amit?
Yeah.
So first of all, thank you so much, Dr. Lippy, for the invite, and Chitra ma'am for organizing such a learning session. So Dr. Rohit, I second to what Dr. Nagesh has said, that this innovation may not have a lot of benefit because the difficulty is what we face as junior is hand-eye coordination is something which is very, very important. We let juniors spend just let's say a month for that. Hand-eye coordination and handling the microscope under the instruments under the microscope. How do you think that that step can be overcome with your innovation?
No, I'm not saying that I overcome my innovation. I'm just trying to say that sometimes where it's difficult to understand what my point is when we are teaching. Let's say if a junior surgeon is
But that you
operating
can
and
use a video to show, because
yes,
sometimes depth perception, hand-eye coordination, these things might be very difficult for a junior. And if they get used to these things, like you were just holding the lens with the hand while inserting, you were not using any instruments. So
yes,
that might be a difficult thing because you teach the juniors how to angulate the instruments or how to hold the lens with the help of the instruments. I think that's it from my end.
Yeah.
Thank
So-
you, Doctor.
We'll move on to the next speaker.
Hmm.
I would like to invite Dr. Akshat Tyagi to please share his screen. Dr. Akshat will be speaking on a guide to CTS implantation, and Dr. Akshat is from Isha Netralaya. Can you please
Hi,
share?
everyone. Yeah, am I audible?
Yes, you are. You can go ahead.
Okay. Just let me know if the audio
Yep,
is
absolutely.
clear in the video.
We are yet to see your screen.
Just a second.
What's happening?
Just a second. It's asking me to leave the meeting.
Okay.
Can I
So
just
yeah, you can just log out and
Yeah.
log in. Ma'am, would you like to go ahead with the next speaker?
Yeah, I'll do that. So Shruti, are you ready? Okay.
Yes,
So
ma'am.
we have our next speaker is going to be Dr. Shruti Anand Sapkal. She's a Vitreoretina Fellow at Isha Netralaya, Pune. And she has a very interesting video to show us. Let's see it and have some interesting discussion. On to you, Shruti.
Yes, ma'am. Thank you, ma'am.
Everyone, our topic today is surgical repositioning of iatrogenic intralenticular steroid implant. Our patient, 55-year-old male, was diagnosed with PDR and CSME in status post multiple anti-VEGF injections with best corrected visual acuity of 660 in the right eye. OCT was noted and Ozurdex implantation was planned. On day 1, we could see the Ozurdex implant breaching the posterior capsule, so surgical management was planned. 2 side ports were made, the anterior capsule was stained. AC entry was done and a nice continuous curvilinear capsular axis was done. After that, careful hydrodelineation was done and the nucleus was then emulsified with the help of phaco probe. After carefully removing the nucleus, viscodissection was done and the epinuclear sheet was separated. It was seen that the anterior vitreous face was intact, so the Ozurdex implant was repositioned back with the help of a Sinskey hoe and a careful cortical dissection was done. A 3-piece intraocular lens was implanted into the sulcus and optic capture was done. Postoperatively, we can see that the edema was resolved, its complication, and which may require surgical intervention as soon as possible. Thank you.
That was a very good take-home message you had in your talk, because an inadvertent mistake can happen. So Murli, since you missed out on the last time, I would take this question with you. Now, how do you think we could have avoided this thing to have occurred of the implant going into the lens? So
Yes, ma'am. While
you have
inject,
to unmute yourself, Murli.
am I audible, ma'am?
Murli,
Sorry,
yes.
yeah, came late.
Yes.
Actually, the Castro-Visual caliper that we used to measure 4 millimeter from the limbus before we insert the Ozurdex or give any intravitreal injection, sometimes the screw gets loose. So the retina people have a very good trocar. The back of the trocar is positioned at 3.5 mm. I think the 3.5 mm entry is very critical. The other mistake that commonly is done is that you have to aim to the center of the globe. Many people tend to go parallel, so that really results in an inadvertent capsular puncture and the implant being positioned intrareticularly or tricot being injected into the lens. So it can result in a lens touch. So the key is that you need to have a good caliper to measure the back of the trocar that the vitreoretina surgeons use, that is calibrated for 3.5 mm. Use the infratemporal quadrant. And with your Ozurdex implant or with your intravitreal needle, if you are giving tricot, you should aim at the center of the globe, towards the optic nerve, rather than go parallel to the iris plane. So I think these are the
that is directed into the vitreous cavity, not more anteriorly. Dr. Sonal, now, how soon after the injection do you actually think the cataract happens? And if so, when would you operate on them?
No, I think this was a very pertinent video in which they have done that immediately, and one should not be waiting.
Yeah, true. True, but sometimes this is a case where the cataract would happen immediately. But if it was a lens touch, just a lens touch, which could happen with an intravitreal injection or even a post-Pallas plana vitrectomy, sometimes, it's better to wait for a period of 6 weeks for that area to fibrose.
Yes,
it gets fibrous. And sometimes in those kind of cases, the cataract doesn't happen right away. It could happen in a month, 6 weeks, sometimes even 6 months, 1 year also.
Then it is visually significant for the patient. And
but in this kind of a situation, I think the cataract does happen right away. I think with the implant sitting right inside. Yeah. So I think, shall we? Whom is a previous speaker, Akshat ready?
Hello.
Yeah, Dr. Akshat, can you share your screen?
So Anuj, why don't you take over? Yes.
Yes, ma'am.
Is my screen visible?
Yes, it is. You can begin your video. I'll tell you when we can see it. Do you have any audio overlay?
Yeah.
Great. Okay.
Just let me know if the audio is.
Hi everyone.
Yes.
Okay.
Fitted lens presents a major challenge during cataract surgery. In this video, I'll be discussing an easy way to fix a capsular tension segment for the management of subluxated lens. This capsular tension segment has two eyelets that sit inside the bag, while the central eyelet lies on a higher plane that is above the level of entire capsule, as shown in the side view on the right. A 14-year-old boy presented with a cataractus lens with a subluxation of around 6 clock hours. Cataract surgery was performed where a CTI was placed, but the bag still wasn't stable. Therefore, a CTS was planned. Here we can see the subluxated bag with the CTR already in place, along with the residual cortex that the cataract surgeon is removing. It's crucial to have dispersive viscoelastic injected over the area of zonular dialysis at all times to prevent vitreous prolapse into the anterior chamber. A localized peritomy was performed in the inferior quadrant. Leaders were cauterized. A 2 by 2 mm partial thickness clearer flap was fashioned with a crescent blade. The main port was enlarged to facilitate entry of the CTS. A 26 gauge needle was inserted underneath the scleral flap, and a 6-0 proline suture was threaded inside it from the opposite side. The needle is then withdrawn and some of the suture is left outside the eye. Now the other end is threaded through the central eyelet of the CTS. An adequate size bulb is then created with cautery. CTS is then inserted into the anterior chamber and subsequently into the bag, keeping in mind to place the central eyelet over the anterior capsular margin. The other end of the suture is pulled, and as we can see, the CTS gets placed in the bag. After that, we trim the proline and cautery the end to make another bulb so it stays in place. The superior cortex was removed and a 3-piece IUL was placed inside the bag. The main port was then sutured. Scleral flap and conjunctiva can be closed either by using a glue or sutures. Thank you.
Thank you so much, Dr. Akshat. I think that was very well managed with a well-centered IOL right in the end of surgery. Dr. Bhavya, are you there? I would just like to know from you anything different that you would do in a case like this, and how do you see these cases in terms of long-term prognosis?
So in terms of long-term prognosis, my main personal this thing is there's an everlasting dilemma that I usually face. We usually, keep a VR in the loop most of the times. So for most of the even for people who are beginners or people who are freshers, there's always a very common thing which I learned it from my gurus, which was when to take up a case and when to refer. So there's a very thin line of difference. Even in bad subluxated lenses, in which I use CTR, etc., etc., I specifically remember that in my learning curve, I used to do it in normal cases in such a way that I have an exposure of these particular spectrum of things. I started using CTRs, of course, first, using them in case of torics, and CTSs. Eventually, I used it once or twice, but for my particular cases, I had the liberty to have a VR backup, and eventually a VR rescued the entire case and completed the SFIOL when I was learning it through. So this was my journey, and probably Dr. Akshat has managed it pretty much wonderfully.
Yeah, of course, he's managed it very well. I would like to invite our judge, Dr. Vidya and ma'am, if you are there, would you like to add some comments?
Vidya,
Yes,
are
ma'am.
you there? She
Yeah.
was there. Yeah. Yes,
Yeah,
Vidya. Yes, Vidya.
I think very nicely presented video and very nice teaching points on this. I would like to add like CTS works very well when it is used early, and it has to be very thoughtful thing, and it is more of a decision making tool. I would consider that as a decision making tool rather than a technical one. So that would be my take on this. Like, no, in case of progressive zonulopathy, it's better to use Sioni ring. And rest of the cases, as mentioned earlier, CTR definitely works. And CTS in case where there is a focal zonulopathy. So that would be the thing, but very nicely demonstrated technique.
I felt one question I would take one or two here. Tamil, why is it that people use 60 proline? Why can't you use a 5? Why can't you use a 7?
Ma'am, proline for flanging 60 is ideal because 70 is too brittle and 50 it will be too stiff to create a flange. So I think 60 is optimal when considering the stiffness and the breakage point also.
I know 50 you will end up with a congenital erosion, because it becomes bigger. And Nilesh, this is again the last question today. Would you think there are some people flange it without a scleral flap as he did it? Would you think that could also be done?
Ma'am, I won't prefer with 6-0. With the SFIUL, with the
Yeah.
SFIUL, we can still do transscleral
Yeah.
flanging. But
Yeah.
for proline 50 proline, I think it will be too big to sit there.
Yeah, true. Yeah. Thanks a lot. Sorry for butting in between, but I felt these things need to go across. So, Tamil, would you take on Apurva?
Yes. I would like to invite Dr. Apurva, who's a DNB resident from Sri Ganesh Vinayak Eye Hospital, Raipur. On to you, Doctor.
Good evening, everyone. I'll just share my screen now. Is my screen visible, sir?
Yeah.
I've started sharing it, be.
Yes, now it's visible. Can you just press the play button?
Yes.
You have an audio overlay?
No, I'll be speaking soon.
Oh, okay.
So good evening, everyone. This is Dr. Apurva, DNB resident at Sri Ganesh Vinayak Eye Hospital, Raipur. And today we will be learning the tunnel suturing in SICS with the help of a DIY model to demonstrate the exact technique of suturing and to understand what is exactly happening under the microscope. In this, on a canvas board, we have drawn a representative cornea and limbus with a frown incision given up from length limbus to limbus. And to represent the 10-0 nylon, we have used a red color yarn to highlight. Whenever we are doing the suturing, sitting at 12 o'clock, first we have to take the bite from the distal end and then come to the proximal end. And while holding the suture, you have to make sure that you are holding it at 2/3 and 1/3 position. When you make the knot, after making the knot, what we tend to do is suddenly make the second knot. But before that, the important step is to lock the suture and then go ahead with the second knot. After that, again, you follow the dictum of the 3-2-2 or the 3-2-1 to complete your suture. So, whenever you are placing the suture, you have to make sure that it is equidistant superiorly and inferiorly from the wound, and adequate distance should be there. If you're making the another suture, you have to make sure that it is not directly straight but perpendicular to the wound or the incision that you have created to make it astigmatically more neutral. And again, with a similar technique, first you knot and then lock and then complete the suture. Whenever placing the suture, we have to make sure that all the sutures are equidistant from the wound as well as equidistant from each other, so that the suture become astigmatically more neutral. And this is the technique of the interrupted suture. The other technique that we can use is to create a box suture or the inverse square suture that we use. For that, we have to take the bite a little paracentral and from the distal end, again coming to the proximal end. While coming to the proximal end, sometimes we, as a new job, we face difficulty because of all the viscoelastics and the saline that is there in vivo. So this demonstration becomes easy to understand what is exactly happening. And then you take the diagonal incision. At this point of time, make sure that you don't entangle your suture material. And then take the bite again from the distal end to the proximal end, a little paracentrally. After doing this, again you tie it with the first bite that you have taken. The advantage of this over the interrupted suture is when you learn it definitely has a more learning curve, but when you learn it is more stable, more less time consuming, and more astigmatically neutral and covers a more surface area. So again you lock it and then you go ahead with the second knot and then the third knot. Whenever you're placing the knot, make sure that you always bury it, or whenever possible, bury it on the scleral side to decrease the foreign body sensation post-operatively. So, as a budding surgeon, complications are inevitable, but the only thing that we can do is practice, and that is what it is, that practice makes the surgeon perfect. Thank you so much.
Thank you, Dr. Apurva. I just want to know the inputs from Dr. Nilesh. Actually, while training, we ask residents to practice in goat side, which gives a better tissue feel. And also, like previously mentioned, like when we practice under the microscope, they also learn the hand and eye coordination. So, what would be your take on this?
Yes, ma'am. I perfectly feel that we should not practice too much on these. These models are good for the basic teaching, like just to get the orientation, like how the needle should move ahead. Because the finer movements it takes time to pick up. But once you are like well versed, we should not keep practicing on this too much. Once you know the orientation is there, immediately move on to the next step and start practicing under the microscope. But I'd like to point out, ma'am, this is the X suture is my go-to suture also. I don't use interrupted sutures in it. Most of the cases, be it phaco converted to ECC or a SICS, I try to do the X rather than the interrupted suture.
Any specific reason why you don't prefer?
Ma'am, as it was mentioned by Dr. Apurva also, it is more astigmatism friendly. So there is even tension, so I never get a astigmatic surprise after the surgery.
SSS can be done either superior or temporal. So what do you want to comment on the surgically induced astigmatism of these two approaches, superior
No,
versus?
once the interrupted suture is there, the tension is not even on the incision. So even if we are sitting temporarily and ECC is, I enlarge a phaco to a ECC wound. If I do a X suture, the tension is even on entire wound. So it doesn't create an additional SIA.
Dr. SK sir, the first difficulty a beginner surgeon would face is adjusting the tension or the tightness of a suture. It differs when it is done under air or a viscoelastic. So how do you think that can learn better and adjust the suture tightness?
Yeah, I just want to comment on the suturing technique here. Actually, it's not only the technique of placing the sutures, interrupted or box suture, whatever it works well in your hands, you can put. Because it's mainly the external groove incision where you make. That is important. It should be away from the limbus, at least 1.5 millimeters away from the limbus, and your entry wound, which should be just close to the limbus, just maybe 0.5 millimeters into the limbus. That will definitely reduce your astigmatism, and the configuration of your external groove incision, as she has shown here, is a frown outside and smile inside is what is going to give a excellent outcome as far as the astigmatism is concerned. And putting the sutures, I actually prefer box suture. I usually place a figure of eight suture if at all I'm doing a SACS, and that works well. Of course, I have not studied my astigmatic impact of these particular suture. And one thing what I noticed from her this thing presentation is she has put a suture in the center which is vertical, and towards the periphery the other two sutures are slightly it's angled. Is it because she is directing it radially? That's why the sutures are placed in that way. In that particular area, it is radial. So that's what we aim in corneal transplants. So wherever we are putting the suture, it should be radial in that particular area. That will reduce the astigmatism. That is what she wanted to convey there, Dr. Purva.
Yes, sir. Actually, the point that I wanted to convey is that it's not necessarily you have to play the straight incision. You have to follow your incision that you have made to reduce the astigmatism, sir. If you are putting a straight incision over the curved border, it will create more astigmatism than if you are following the anatomy and putting it in the direction of the wound, sir.
Yeah.
Tamil, anything else before we go on to our next?
Yes, though SSS is a self-sealing tunnel, I think if at all we have any tunnel complication, either a buttonhole or premature, I think putting a suture is really important. And most of the cataract surgery patients are having an against-zero astigmatism. So I think making a temporal a sclerocorneal tunnel is going to negate already existing astigmatism. And if you're planning a superior sclerocorneal tunnel, I think it is better to put a suture so that we are not going to induce more astigmatism. These are the points which I want.
Yeah. Who's the next speaker?
Next speaker is Dr. Habiba Darwajkar, and she will be speaking on the workup of mature cataract. Please share your screen. She's a PG resident from KIMS, Mangalore. Dr. Habiba?
Yes, ma'am, I'm sharing my screen. Good morning.
Is it visible, ma'am?
To invite you all
Yes.
to embark on a
Visible
journey
and
from
it's
darkness
audible?
to illumination.
Visible and audible. Please go ahead.
Good morning. Today I would like to invite you all to embark on a journey from darkness to illumination through a valley of shadows towards the mountain of light. So before we proceed, let's look at the workup of immature cataract. It's like taking a stroll across a flat ground. It's smooth, predictable, and easy to navigate. Whereas the workup of mature cataract is like an uphill trek with all sorts of tricky terrain. So why is the workup of mature cataract different from immature? To unravel this, we need to head on a trek to the summit of Mount Mature Cataract, wherein we encounter 4 checkpoints. The first one is careful anterior segment evaluation of same and contralateral eye, then fundus not visible, difficult biometry, and finally patient counseling. So let's head to the first checkpoint, which is anterior segment evaluation. In the ipsilateral eye, we look for presence of guttae, we look for anterior chamber reaction, poor dilatation of pupil, and the depth of anterior chamber. So early detection of these would warrant tailored surgical strategies. In the contralateral eye, we examine the lens status to look for presence of posterior polar cataract and postoperative aphakia, which is suggestive of a difficult surgery. We also examine the contralateral fundus, which helps in prognostication. So these findings are then anatomically reassessed with the help of anterior segment optical coherence tomography, when we look at the depth of anterior chamber as well as the integrity of the posterior capsular bag. Fundus is examined with the help of B-mode ultrasonography. So advancing to level 2, fundus not visible. So testing for potential vision is quite a daunting task in a mature cataract patient. We employ something called macular function test, which can be OPD based tests that are universally available, like perception of light and projection of rays, Maddox rod test, 2-point discrimination, and entoptic phenomenon. Whereas there are equipment based tests available as well. These are the laser interferometry, focal electroretinogram, critical flicker frequency, and the visual evoked potential. So moving to level 3, biometry. Optical biometers like IOL Master 500 cannot be used in dense media opacities like mature cataract. Hence, we employ advanced technologies like IOL Master 700. We can also use a more universally available technique called the immersion ultrasound biometry for measurements. So before we proceed, we need to counsel the patients regarding the unpredictable course of disease, its unpredictable outcomes, and various dangers that can be encountered. So to conclude, the workup of mature cataract is like a double-edged sword, and it requires meticulous planning and flawless execution to reap the reward of restored vision. So congratulations on restoring the vision of your mature cataract patient and making it to the summit of Mount Mature Cataract. Thank you.
Thank you, Dr. Habiba. That was very well explained, smart pre-operative plan for a mature cataract. I would request our judge, Dr. Aarti ma'am, for her comments.
I think you've highlighted the important points like pre-op workup and counseling. I really don't think that I have anything to add.
I request Dr. Nagesh sir. Sir, what are your intraoperative methods or ways while dealing with such cases, mature cataracts?
Yeah, as she has already said, preoperative workup has should be meticulous and also assess the grade of the cataract while looking into the mature cataract. Sometimes you can make out the hardness of the cataract, so you be prepared for a hard cataract, or sometimes it may be a Morgagnian premature cataract. It can be very soft nucleus also sometimes. So be prepared for that, and also be prepared for Argentinian flag sign, because sometimes these are intumescent. So be prepared for that also. So you know how to handle the intumescent cataract, make a small recess initially and then enlarge it in whatever way you can, whatever way you are learned. So these are my intraoperative maneuvers.
Okay, sir. Ma'am, would you
Can I
like to
ask a
comment?
question
Yeah.
here?
Yes.
Yeah.
Yes,
Yeah.
ma'am.
So, Dr. Habiba, did you use the photographs of your own patients, or were they taken from internet? Because there was one photo where there was a English lady here.
Yes, ma'am. That is my own picture.
All of them?
Most of them are own photographs, ma'am.
Okay, fine. Thank you.
Thank you, ma'am.
So next speaker, shall we go on to?
Yes, ma'am.
Yeah.
I'd like to invite Dr. Shafi Chopra. Can you please share your screen? Dr. Shafi Chopra is a fellow at CFS Delhi, and the presentation is cataract surgery in post RKIs. Dr. Shafi, are you there?
Yes, sir. I am sharing my video. Just a second.
Okay.
Sir, is my video visible?
Yes. Can you please? Do you have an audio overlay?
Yes, sir. Yes, sir.
Okay. Just start playing it.
So can you please tell the voiceover comes on all?
Yeah. Just start playing it. No, there is no voiceover. Shafi, there is no voiceover.
RKIs are challenging.
Yes. Now we can hear it. Go on.
Okay, sir. Just a second, sir. Most RKIs are challenging because the old radial guts make the docking unstable. The anterior chamber fluctuates and the cornea becomes irregular. There is also added incision stress and a risk of gas breakthrough during femto. This case was a 55-year-old male with a 16-cut RK done 25 years ago. He presented with dim vision and fluctuating diffraction. We planned flex with a monofocal IOL. Preoperative biometry shows a flat cornea with a mean K of 38.5 diopters. Axial length is 24.46 millimeters with an ACD of 3.22 mm. Using the final K of 38.3 diopters, all formula cluster around a 23 diopter lens. In post RKIs, the astigmatism is irregular, so multifocal and EDOF lenses were avoided. Toric was also not preferred due to the unstable axis, and monofocal gives the best contrast and predictability. Proceeding with docking. During docking, in post RKIs, we use the lowest possible attenuation pressure. Centration is always on must be uniform. If docking is imperfect, we gently de-dock. We also monitor the anterior chamber stability and stay alert for the gas breakthrough along the old RK cuts. Then starting with the laser application with capsulotomy laser firing and the fragmentation of the nucleus. For femto in post RKIs, we use higher capsulotomy energy of around 8 microjoules with deeper cuts around 800 to 1000 micrometers for complete capsulotomy, with tight spot spacing of around 5 micrometer horizontal and 15 micrometer vertical. Incisions are always placed between RK cuts and we ensure no skip areas. Centration is done manually because RK scars distort the tracking. Now begin with the phacoemulsification part. We begin by creating a side-cut incision precisely between the two adjacent archaic cuts. Next, the main incision is fashioned as a scleral tunnel approach rather than the clear corneal entry. This is intentional because a scleral tunnel distributes the stress externally and prevents the gaping of the archaic incision during the phacoemulsification. Then we assess the capsulotomy edges to ensure a clean, continuous curvilinear before moving ahead. We then perform a gentle hydrodissection. The fluid wave must be very controlled. Throughout phaco, we maintain very low total height and the minimal turbulence to prevent the transmitting pressure to the old archaic cuts. The phaco tip is kept central, away from the peripheral incisions, and the nucleus is emulsified gently using the low vacuum and the controlled aspiration. Our goal is to complete the cataract removal without causing any bone stretch or the destabilization of the cornea. Irrigation and aspiration are then performed carefully, again keeping fluidics low to avoid the fluctuation in the anterior chamber that in the bag. In post-archaic cases, a monofocal lens is preferred due to the irregular astigmatism. Then we switch the main tunnel. Post-operatively, vision improved to 20/20 with minus 0.75 diopter, and all archaic scars remain stable with excellent patient satisfaction. Thank you.
Thank you so much, Dr. Shafi. I think that was a very good visual outcome as well as a refractive outcome for your patient and very well delineated on the precautions to be taken when operating on post-RK eyes. Dr. Bhavya, are you there? So, if Dr. Shafi, can you stop sharing your screen?
Yes, sir.
So, Dr. Bhavya, would you like to add any points regarding post-RK eyes and cataract surgery in them, especially in terms of avoiding refractive surprises in biometry? Dr. Vidya, ma'am, are you there?
Yes.
Yes, ma'am. Ma'am.
So, yeah, as a very beautiful video and nice demonstration of all the points. I feel the post-RK eyes, the cornea matters more actually than the cataract. And wound placement is the most important thing here. It plays a very important role both surgically and also the refractive decision also. So she has actually highlighted all the technical challenges, and as mentioned earlier, the patient counseling is equally critical in this eyes because it's better to aim for slightly a myopic outcome than emmetropia, because sometimes these eyes over the period of time can shift to hyperopic shift. So it's better to have a slightly myopic correction at the end of it. And taking care of the RK wounds are very, very important. In case if it gapes, we need to be prepared to suture and secure the wound. So that's important. So all the technical challenges, everything she has highlighted very well.
Thank you. Thank you so much, ma'am. Excellent video. We'll move on to the next speaker. Chitra, ma'am, would you like to introduce the next speaker or should I go ahead? I think I'll just go ahead with the next speaker while Chitra ma'am just comes.
No.
Yes.
No. One more question which I had, I didn't realize I muted it. One more question, like supposing you had a choice of biometry, you have IUN Master 700 and you have IUN Master 500. Which one would you choose and why in these post-RKIs? Anybody wants to answer that? Because I thought when we're talking RK is such a relevant topic, biometry, what is that extra thing which we need to remember? Or maybe I would tell this point is basically there is an alteration in both the anterior and the posterior corneal curvature. So if in IUN Master 700 you are able to measure the posterior cornea also. So by the regular keratometric index of assuming the anterior posterior corneal ratio as 1.3375 no longer exists. So with an IUL Master 700, since the posterior corneal curvature is incorporated, so it gives a more precise K value measurement, whatever is possible in these extremely flat corneas. And then if you use the latest generation formulas, and now we know using Keynes formula, Keynes keratoconus formula, or the Barrett Universal 2 formula, or sometimes they say even SRKT is good. These are the different formulas which could be not SRKT. I would not ketoconus. I'm sorry. Using a Barrett formula in case
Barrett's true K works very well in these
Okay, very
cases,
well.
the
Yeah, yeah.
post-RK patients,
Yeah.
with history or
I
without
suddenly
history.
went off into ketones. Yeah, exactly. That was one very good thing.
Yeah.
Thanks a lot, Anuchit. And thanks a lot, Shafi, for such a wonderful presentation. We go on to our next speaker, Dr. Genia. Are you there?
Yes, ma'am, I'm there.
Genia is actually a long-term fellow from Bangladesh Eye Trust Hospital, Raya Bazaar, Bangladesh, and she's going to show her interesting video.
Yes, good evening, everyone. And thank you for giving me the opportunity to share my experience in this wonderful platform. I'll just share my screen. Oh. Okay.
Yeah, right.
Am I visible and audible?
Yeah.
Yes.
Okay. Thank you. I'm just starting. So today I'm going to share a technique of management of posterior polar cataract. So in this case, a side port is made, Blu-Rex is given, a biplanar incision is made, and ocular ophthalmic surgical devices are given. Well-centered and controlled capsular rexis is being made to ensure stable maneuvering. The rexis should not be less than 5 millimeter here, as it can cause difficulty in removing the epinucleus. Then gentle hydrodelineation is being performed. The aim was to avoid hydrodissection and rotation to protect the posterior capsule. So as the patient was a 65-year-old lady and there was mild central nucleus sclerosis, so the plan was to debulk the nucleus in a V pattern. Here the plan was to make a deep trench to completely separate the central part of the nucleus from the peripheral part. So in this way, for the forces, the pressure, the vacuum, all are directed centrally and anteriorly, avoiding stress on the posterior capsule. So as the nucleus was quite soft, it was a little difficult, but eventually the whole central part of the nucleus was separated and it was completely aspirated. It was being aspirated, and finally the central part was completely aspirated with low vacuum, low power, and mostly with the vacuum. Then viscoprolapse of the epinucleus was done, and epinucleus was aspirated with no power and only with vacuum. In these cases, epinucleus is preserved as a protective cushion, and there should be no rush removing the epinucleus, and it should be done gradually, as tractioning force can suddenly detach the posterior polar component, leading to posterior capsule rupture. So slowly the epinucleus was gently removed here. And then gentle aspiration of the cortex was also done under controlled fluidics. And every time when we retract the instruments, copious amount of ophthalmic surgical devices should be given to maintain the anterior chamber. So as we can see here, I got lucky. There was the posterior capsule was intact, and successful in-bag intraocular lens implantation could be done. So the teaching pearl here is that posterior polar cataract, the epinucleus is your safety shield, and V-pattern phaco allows central nuclear debulking while keeping all forces away from the posterior capsule. Thank you for your patient hearing.
That was a wonderful video, Dr. Genia, and you brought out the principles and for safeguarding a posterior polar cataract beautifully. Very good. So taking this forward, Dr. Murli, I wanted to ask you, you're there, Dr. Murli?
Yeah.
Murli, she said no always hydrodelineation. Now, how would you avoid an accidental hydrodissection while you're doing hydrodelineation? Okay,
The
is there a
technique
tip for
was
that?
described by Chi-Soon Fai that when you do the hydrodelineation, you should enter a plane that is greater than the height of the PPC. So if you take care of that and use a gentle this thing, you can avoid. Of course, if you are not able to make out the height of the PPC because the cataract is so very dense, then I may choose to avoid hydrodelineation entirely and do a mechanical delamination. But if you are able to see the PPC properly, the plane of hydrodelineation should be such that it should be greater than the height of the PPC. That is what is classically described.
What exactly you mean height of the PPC?
Let's say
How
that,
much it is lifted up, you mean?
how much it is lifted up, that much you should depress your needle inside.
Oh, that much.
So that when the fluid wave goes, it goes above the plane of the.
Yes, that's a wonderful tip. Sonal, wanted to ask you two questions. I'm allowed one. One is, what would be the extra imaging device you would want to do in a posterior polar cataract, the way it stands today?
So, ma'am, basically, I think in this particular posterior polar that she has demonstrated, you're asking in general.
Yeah, in general. In this or generally?
So I think with the advent of flax, I think we have such a good delineation of the nucleus. We are not using flax at our center; it's a government center. So, but seeing all the wonderfully managed posterior polar cataracts, the best would be to delineate it surgically, and all the other steps would follow then. So that would be the go-to step, because if you've done some other imaging and then you are doing during the surgery, you're not doing the proper layer wise demonstration, then it will not be very helpful. So I think visualizing the nucleus in the flax system would be the best way to go forward,
and giving it the right amount of offset. But I also wanted to add that we have started doing routinely preoperative OCT for all these PPC cases, because by that you can see that the posterior capsular line, if it is continuous on the ASOCT, then we've done a case series study. You can even do a routine hydro and manage the whole case. And if the piece is discontinuous or some of the contents of the lenticule lens matter is actually in the patella fossa, that means it's an open PC. Then you have to be very strict about only doing a hydrodelineation and very safe surgery, as if the parameters are, keep the parameters low and all that. One last thing which I wanted to ask, anyway, Murli or Sonal, whichever, supposing you are putting the 3-piece IOL on the sulcus in a case of a polar cataract, when you've had a PC opening and you do an optic capture, would you do something? What would be your IOL par calculation? Would there be any change, or how would you do it? Murli, you are muted.
If I'm doing an optic
Difference
capture,
in
then I would
0.5.
not alter the power. If it is in sulcus, reduce by 0.5, madam. If I'm doing an optic capture, I may not alter the power.
Yeah, that's a very important thing for all of us to remember, that if it is going to be optic captured, we do not change the parameter, change the IOL power at all. So the next, on to Tamil, the next speaker. Wonderful presentation.
Next speaker is Dr. Pranesh Ravi, who is a consultant cornea, cataract and refractive surgery from the Eye Foundation, Hosur. On to you, Dr. Pranesh.
Thank you. Thank you for the introduction, ma'am. Is my video visible, ma'am?
Yes.
Yes.
Okay.
My name is Dr. Pranesh Ravi. This is a 60-year-old gentleman who presented with decreased vision secondary to endothelial compromise. His visual outcomes with a planned triple procedure were unlikely to be optimal, so we decided to proceed with phacoemulsification first. The central and paracentral cornea show significant opacification, making visualization challenging. In addition, corneal edema typically worsens during phacoemulsification, further reducing clarity. Although the cataract itself is not very dense, the limited view, particularly for the finer steps of surgery, necessitates additional measures. Therefore, we plan to use an illuminated light pipe to enhance intraoperative visualization and assist with the procedure. Recognizing that corneal edema can worsen during surgery, I applied a layer of viscoelastic to the anterior lamella. This measure was taken to prevent the anterior cornea from absorbing fluid and consequently exacerbating the edema. Retroillumination facilitated a comfortable capsulorhexis, eliminating the need for a light pipe system. Corneal edema remained manageable. Should improved visualization be necessary, I can administer 100% glycerin intraoperatively to reduce edema. However, I completed the case successfully using a light pipe, ensuring a smooth progression until the capsulorhexis. Hydrodelineation. No initial immediate concerns were noted. However, upon commencing phaco, the worsening of the edema was observed, necessitating further assessment. After completing the sculpting, I attempted to chop the nucleus, but was unsuccessful due to poor visualization. I attempted to chop the nucleus using a zero phacoemulsification chop technique, as it was a soft nucleus. Although I achieved a few cracks, the chop was not entirely successful. When unable to extract the nucleus from the capsular bag, I viscoed the soft nucleus using viscoelastic material, which allows for straightforward emulsification. I am also able to complete the phacoemulsification without difficulty. The assistant holds a light pipe from the corneal periphery, providing improved visualization for delineating the posterior capsule. Following uneventful nucleus removal, irrigation and cortex removal were initiated. While most cortex was successfully removed, I encountered difficulty around the main port. The patient's positive pressure caused the iris to become floppy, complicating cortex removal in that specific area. To efficiently address the remaining cortex, especially given preceding challenges, I decided to implant the intraocular lens, IOL, and then carefully rotated to loosen the adherent cortex. This maneuver proved successful and the cortex loosened. The concomitant iris prolapse unexpectedly facilitated improved visualization and easier completion of cortex removal. The tissue was repositioned, its pores hydrated, and the surgery proceeded uneventfully. Finally, a bandage contact lens was placed and the procedure concluded. That was my take on this case. Finally giving an uneventful outcome for this patient. Thank you for your patient listening.
Dr. Pranish, it was well presented, and you have multiple comorbidities in this case: corneal opacity, moderately sized pupil, floppy iris, and a sticky cortex also. I would like to ask Dr. SK sir, in case of patients having a poor endothelial cell count, when do you plan to do a cataract surgery alone or along with the lamellar keratoplasty?
Actually, this is the best case for cataract combined with the DSEC or DMEC. Actually, the patient has got a localized corneal edema. This is stage 2 to stage 3, a fuchs endothelial corneal dystrophy. And there is corneal edema, and this is going to progress. So once the cataract is done, if you do only the cataract surgery, the patient is going to progress, and you may end up with the DSEC very soon. So you could have combined DSEC or DMEC with the phacoemulsification here. And of course, like it is a little difficult if it is in the central pupillary area, visual axis. If the opacity, or this is not opacity, it is mainly the edema which is actually blocking the view, and you can slightly tilt the eye to one side and do your maneuvers and do the surgery. Chandelier illumination is of course tried from behind in the anterior vitreous or from the in the anterior chamber itself. You can keep this piped light and do surgeries even in a dense corneal opacities if the patient is not willing for a combined procedure. But this is a right case for a combined procedure.
Okay, so patient was only affording for cataracts, so then I thought I'll do the cataract first. The inflammation profile also will be lower when I do a D6, so I plan for a D6 next time. Thank you for
Yes.
that.
Have you followed up this patient? Patient
Yes,
follow-up?
madam. Yes,
But
madam. He's doing
Pranesh,
fine.
you have
So,
used that AI voiceover,
yes, sir.
and the voice actually the person is not able to pronounce your name also properly.
Pranish has to do something different. You know him.
Okay.
Okay, take a next question, Tamil. Before next
Question,
question.
Dr. Nilesh. In cases with poor endothelial cell count, we usually prefer to use a highly dispersive viscoelastic. Have you noticed a little bit of wound burn when we are using highly dispersive viscoelastic, and what are the tips to avoid it because of the thermogenic nature of this?
And in these kind of cases, I usually try to make the wound little larger than the sleeve size, so that there is little amount of fluid egress that will cool the surface, and also not to fill like what I use is soft cell technique, not to use too much of viscodispersive. Coat the endothelium, but use the bulk of the central bulk to be of HPNC. So that way, it creates a cushion and doesn't give that thermogenic effect. So these are the two tips that I generally use.
Additionally, I also
I
make
think whatever the technique you use, soft shell technique or whatever, like even the regular HPMC is sufficient. But you start your phacoemulsification once you're inside the anterior chamber. While going through the wound itself, if you start phacoemulsification, go to your third position, that will cause what is called caramelization of the visco and can cause a wound burn. So enter into the antechamber, then you start your phaco.
Yeah, sometimes it's better to even wash it off and go into pre-phaco, because it's not the wound burn could even happen if the phaco probe is in the center. You know that if there is, it does get caramelized. So it is better to go to pre-phaco, wash off the viscoelastic in the centered core, and then start your steps. It's a very good video, very good questions. Anything else, Samal? Shall we go on to the next speaker with Lipi?
The next speaker is Dr. Shantanu Gulati. Can you share your screen in the meantime? So Dr. Shantanu is working at Gulati Eye Hospital and Medical Care Center, Jhansi, Uttar Pradesh, and he's going to show us pearls on B hex and B octa. Please unmute yourself and share your screen. Thank you.
Is my screen visible?
Yes.
Hi everyone, this is Dr. Shantanu Gulati, and the title of this video presentation is Preventing Small Pupil Complications in Cataract Surgery, my 4 pearls using the Bhattacharjee pupil expanders, the B hex and the B octa. A 23 gauge forceps is used to engage the expander flanges under the iris. However, in small pupils and especially with the B octa, where there is a greater discrepancy between the ring size and the pupil size, a bimanual technique becomes extremely useful. As you will see across these clips, one hand advances the flange with the forceps, while the second instrument, usually a blunt Sinskey, supports the iris from the opposite side. This provides counter traction and even avoids the need for pupil stretching with Coughlin hooks before ring insertion, because the expansion happens naturally as each flange engages. In many cases, such as those with dense arcus senilis, or when using the B octa, the final flange may lie hidden under the limbus. Blindly searching the periphery risks iris trauma or even descemet membrane detachments. Instead, treat the iris ring complex as a single mobile unit. By gently pushing the opposite visible flange iris unit towards the limbus, the hidden flange naturally moves centrally, where it becomes visible and can be safely engaged. Once the ring is in place, the pupil provides a stable and adequate diameter for the capsular axis, all the steps of phaco, and cortex aspiration. This controlled working space greatly reduces the risk of complications in small pupil cataract surgery. For IOL implantation, the key principle is dialing the lens into the bag without allowing the ring expander to subluxate behind the optic. This is achieved by using a controlled dialing movement that causes gentle flexion at the leading haptic optic junction against the capsular equator. This maneuver creates a small space between the trailing haptic and the ring, preventing the two from contacting each other. With this controlled flexion and spacing, the IOL slides smoothly into the bag. The fourth pearl, specially important for surgeons using these rings for the first time, is understanding post-operative iris behavior. A thin atrophic iris may present on post-op day 1 with a pupillary membrane or an irregularly shaped pupil. This should not be discouraging. With appropriate steroid and dilator therapy, these pupils typically settle into a smooth acceptable shape within a week. In eyes with a healthy iris, even post-op day 1 pupils can appear round and aesthetically normal. With these pearls, surgeons new to the Bhattacharjee expanders can adopt them confidently and safely in small pupil cataract surgery. Thank you.
A very well managed case, Dr. Shantanu. I would like to ask Dr. Vidya ma'am, what is your choice of pupil expansion device and why?
Uh, I would say we should choose the pupil expander based on the pupil behavior and not surgeon preference. Like the goal here is a stable exposure with minimal iris trauma. So if the pupil is really fibrotic and you have a dense cataract, B hexa or B octa would be a great choice. If it is you are expecting a kind of iris chaffing and ephes kind of thing, even iris hooks may also be a good choice. If it is a shallow AC or something, we can also choose this thing. What we need to understand is that there is a learning curve in B hexa and B octa, and that should not be undermined. So we have to be very careful in engaging and disengaging. And we need to remember that the pupil behavior is more important in choosing this.
Can we reuse them, ma'am, the rings?
I have no idea. No, I don't think we can reuse them.
I've actually tried that after sterilizing with ETO, and
Yeah.
it works sometimes, but sometimes the ring just gives in and it doesn't dilate the pupil. It just gives in. So I don't think it's a good idea.
It was a beautiful presentation of yours. I'm going to again interrupt. Would you like to put your flanges in a clockwise manner, one after the other, or would you like to do it alternating? And this retracting the iris and then tucking in, beautiful tips you said, but how do you prevent accidentally touching the lens capsule?
So, about the first question, I don't really do it clockwise. It's just based on the visibility. Whatever is visible, I put that first. And for the second part, before moving on to the next step, you always put adequate amount of visco under the iris. So between every two steps, you have to make sure that you put a lot of visco, and that is how I protect the capsule.
Oh, great, great. Wonderful.
Dr. Bhavya, anything you would like to add?
I think he's.
I think we can move on.
Yeah.
Yeah, I would like to invite Dr. Anup Kumar Singh to please start sharing his video. Dr. Anup Kumar Singh is a consultant phacoglaucoma cornea and refractive surgeon from ASDI Hospital at Varanasi, and he will be speaking to us on hydrophilic acrylic IOLs as a scleral fixated IOL when a backup SF IOL is not available.
Is my screen visible?
Yes, it is. Do you have an audio overlay? Dr. Anup, do you have an audio overlay?
Uh, uh, Audio is already on. Is it audible?
No, it's not audible. So can you just speak while you're presenting?
Okay, there is an overlay already. I don't know how to activate it.
No, if you can't activate it, you talk. No?
Yeah, sure. So surgical aphakia management using scleral fixated IOLs causes an extra financial burden over the patient who underwent surgical aphakia following complicated cataract surgery. So here I am demonstrating an easy maneuver for implantation. Here it is beneficial for the patient and also for a surgeon in anterior segments to manage the surgical aphakia using a modified M&A technique and a foldable acrylic IOL and 60 Prolene. The plate haptic of the lens provides an extra surface area for the attachment of the flanks using 60 Prolene. The end of the Prolene is bulbed using a bovine cautery, and the test is used to test the strength of the IOL while implantation. Now, for the ease of the implantation, the flanks are first passed through the cartridge and then lens is loaded inside. Now, marking the sites for the flange attachment. A thorough and good vitrectomy, anterior vitrectomy ensures a better and stable IOL. Now, first passing the first flanks and then alternatively passing the second flank. And then through the main port, without making any additional port, we can just go for the lens implantation, which is foldable. While demonstrating this technique, I have encountered a sudden trouble because of the other blob, because of the plunger, it got detached, but still just taking out that flank and just repeating the same procedure using the free end. Now the centration of the lens was a little bit problematic because of the presence of the vitreous in the anterior chamber. Again, repeating the good anterior vitrectomy with proper and thorough anterior chamber wash ensures the well centration of the IOL, and also using pilocarpine to reduce the size and then air inside the anterior chamber ensures the proper positioning of the IOL. The extra length of the Prolene suture is being bulbed and it is passed subconjunctivally. Following, the case is closed and the main wound is again sutured in order to maintain the anterior chamber tension. Thank you so much for watching.
Thank you so much, Dr. Anup. I think that's quite a novel technique. I would invite Nagesh sir to give his points regarding this, especially about long-term decentration or tilting of these single-piece IOLs over time.
Yes, that is one of the major factor, the tilting of the any lens. Whatever you do, there are multiple modifications of this sutureless SFI also. There are many different techniques are there. Definitely, whatever method you employ, there will be some amount of tilt. You cannot avoid that because slightly it's a blind procedure. And one thing I wanted to tell about this flange is, doctor, you have placed the flange above. I mean, it was facing the iris. It should not be that. It should be below. It should be below the IOL so that this flange should not get in contact with any of the tissues there.
It was
So that
actually
is what
below, sir. I don't know whether
below, is it?
it was.
Okay.
Yeah, it was below
It
because we
appeared
couldn't
like
appreciate it.
maybe. Correct. When you are doing it, it was appeared above. Yeah, fine.
Exactly.
If it is, then it's fantastic. It's good. But usually I don't prefer doing hydrophilic lenses. I'm usually
No, sir, this is not an ideal technique I am
correct.
implanting for all the cases. It is just in case
One of the
where
correct.
patient, yeah, it's not very much affording.
Good.
We can try this.
Fantastic, sir.
This is an
We can
alternative
try
technique.
this. Yes, sir. It's an
Yes, sir,
alternative.
sure.
Definitely. Thank you.
Thank you so much, sir.
Thank you.
Aarti ma'am, do you have any questions for Dr. Anup?
Dr. Anup, I just want to find out how many cases have you done till date?
Very few only, 2 or 3 only, not very much.
Because I mean, if you have long-term follow-up of the patient in terms of inflammation, centration, stability of the
Yeah, definitely.
IOL,
One
it
point
will
is
be
that the centration with the proline, because over the time it will definitely have a tilt. I've done recently, I haven't seen any complication like that so far. But again, I am recommending that this is not a routine procedure to be done for all the cases. Nothing can replace the SF-IOLs. This is just an alternative. So definitely it is not a standard practice. But whatever the point you are mentioning is definitely right. We
I'm
can
still not
keep it in
convinced
contact.
that you can use this technique, but maybe in future presentation you come up with the numbers and studies, and then maybe it will be easy to be
I
convinced.
hope I
Thank you.
should do it more often, but I don't think that is a practice. But anyway, point well taken. Thank you so much.
So, shall we go on to the next talk?
Yes, ma'am.
So, I would invite Dr. John Davis Akara, who's a glaucoma, cataract, and refractive surgeon from West End and Chaitanya Eye Hospital, Kochi. And John Davis Akara is such an innovative surgeon and a speaker of great quality. So, let's hear from him. Unmute yourself.
Thank you, ma'am, for the kind introduction. So I'm going to be talking about a patient with glaucoma and a small pupil. So I call it navigating the glaucoma gate and the bleb barrier.
Glaucoma gate, bleb barrier, and
Is my
pupil
audible?
This
yes,
74-year-old lady presented with advanced glaucoma, status post, strab in both eyes, and immature cataract left more than right. Note the awkward position of the right hand side port at 10 o'clock position because the bleb extends from 10 o'clock to 2 o'clock. The left hand side port is at 5 o'clock position and is used to inject trypan blue dye. Look carefully at 11 o'clock position. See how the trypan blue dye enters into the bleb and stains it. That shows a functioning filtering trabeculectomy bleb. Avoiding damage to the conjunctiva, a temporal clear corneal incision is made. Because of the small pupil, a BHEX 2.0 ring is used. The ring is inserted into the anterior chamber using the BHEX forceps. Then the alternate flanges are tucked under the iris, and this allows the pupil to dilate to 7 millimeters. The third and last flange is often the most difficult one to engage. You might have to use a Sinskey hook to hold it and use a BHEX forceps to bend it and place it under the iris. Then you can continue with capsulorhexis. Here the capsulorhexis is initiated with the right hand, and then halfway through it is found to be difficult to continue using the awkwardly placed 11 o'clock side port. So I switch hands and continue the remaining part of the capsulorhexis using my left hand. Being ambidextrous is a very useful skill for an ophthalmologist. Hydrocannula is used to wash out the capsular remnant and some viscoelastic. Then hydrodissection is done. The dialer is used to dial the nucleus to make sure that the nucleus is freely rotating. Phacoemulsification is done by stop and chalk technique, where first a trench is made and the nucleus is divided into two halves, then rotated, and then the halves are chopped into quadrants. The quadrants are also further sub-chopped into smaller pieces. Care is taken to do the phaco under low parameters to avoid damage to the bleb. Viscoelastic is replenished as necessary, and care is taken to avoid damage to the endothelium as well as the capsular bag. After the nuclear management, cortex is removed by using bimanual irrigation aspiration. First, the aspiration is in the right hand and irrigation in the left hand. And once half of the cortex is removed, the hands are switched and the irrigation is in the right hand and the aspiration in the left hand. The cortex is completely removed and then the anterior chamber is filled with viscoelastic. A foldable single-piece monofocal intraocular lens is implanted into the bag and then dialed into position using the dialer. After the anterior chamber is replenished with viscoelastic, the BHEX pupil expander is disengaged by holding the center of a flange and pulling it into the anterior chamber. After it is disengaged, it is removed by pulling it out with a corner. Viscoelastic is washed out by using bimanual irrigation aspiration. The incisions are hydrated and the pressure is titrated. The preoperative visual acuity was 3/60. Postoperative improved to 618 on post-op day 1, 69 on post-op day 7, and 66 parts on post-op 1 month. Thank you.
That was a wonderful video, John, with lot of take-home pearls. Very good. So, Murli, I'll ask you a question. I think it's something both of us enjoy glaucoma. Now, what we do know that doing a phaco surgery could compromise. Murli, are you there?
Yes, madam. Yes.
Yeah. We do know that a phaco surgery could compromise the bleb survival. So, what would be the ideal interval you would suggest between a phaco, doing a phaco after a bleb surgery? Number one. And in this particular case, would you think of giving any antimetabolites after the surgery, or should it be done along with?
Yeah, madam, I think the gap between phacoemulsification in a patient with a functional bleb should be at least 6 months. So, and I routinely do not give antimetabolites after doing uneventful surgery, but I definitely give them a higher frequency of topical steroids than what I would for a routine case. I give them higher frequency of topical steroids than.
Okay. Then taking this question with you, Sonal, he says he would give a higher frequency of topical steroids. Would you have a particular choice of a topical steroid which you use? Because after all, only a cataract surgery has been done. Would you do anything?
Ma'am, in all my cases of pseudoexfoliation, I generally prefer to go with prednisolone. And because prednisolone drops with moxifloxacin or something, because the initial inflammation needs to be controlled. So if I had flu, if we don't have fluprednate in the common supply, but in the initial period, at least the initial 2 to 3 weeks are very crucial in the post-operative period. So initially I would go for prednisolone, thereafter, and then taper it quickly and move to dexamethasone.
That's a good thought process. Intraoperatively, any maneuvers which you would take, like be careful, which are those maneuvers which would aggravate the inflammation? Any tip you would give in this phaco surgery?
I generally use iris hooks instead of this.
Yeah.
That's more of a institutional issue than this particular thing. And apart from that, John sir has managed it beautifully.
Very
I
well,
don't think I really have anything to add over here separately.
Yes. Murli, nothing to add?
Madam, one thing is if we are doing an SICS in a patient with a huge bleb sitting superiorly, especially a temporal SICS, we have to be careful that forceps don't hurt the bleb. Sometimes these blebs are thin-walled, and if you hurt the bleb, you would trigger a leak in the postoperative period. So that is one thing.
Good. Very nice. Very nice. So on to the next, Taman. Take on.
Our next speaker is Dr. Anurag. He's a consultant anterior segment from ASG Hospital, Varanasi. On to you, Dr. Anurag. Can you share your screen?
Yes, ma'am. Yes. Is my screen visible?
Yes.
Your audio is low.
Yes. Am I audible, ma'am? Am I
better.
audible?
Yeah, better.
Yeah.
No audio.
So good evening, all. So I'll be presenting. Hello. Am I
Yes,
audible, ma'am?
Yes, yes.
Yeah. So good evening all. Thank you Chitra ma'am for this opportunity. So in this video, I'll be demonstrating the meticulous steps involved in the IOL explantation and optic capture. So during the hydroimplantation of the IOL, the surgeon didn't notice the PCR occurred, and by the time he called for help, the IOL was already lying in the anterior vitreous phase. Double Sinskey hook were used for retrieving the IOL, and a thorough anterior vitrectomy was done. Care being taken not to damage the rhexis margin. Now the main wound was enlarged to accommodate for the further instrumentation. With the help of a dialer for counter traction and using a Vanna scissor, the IOL is cut in a single step under optimally filled anterior chamber with dispersive OVD. The care being taken not to damage the iris and the endothelium. The IOL was cut in two halves and then subsequently each half was explanted. The step shown here is loading of a three-piece IOL. The point being highlighted here is that the receding haptic, it lies outside as shown, and then it was loaded, and then this being a B-type Alcon cartridge, and then subsequently check for a smooth movement, and then subsequently was implanted into the sulcus. So the IOL was placed properly into the sulcus, and now it was the optic was captured in the rhexis margin. The care and obviously the point highlighted here is the proper optic capture. End point shown is the ovalization of the rhexis margin. This capture ensures a long-term IOL stability. Thank you. Thank you for your patient hearing.
Thank you, Dr. Anurag. It was a beautiful demonstration of one way of cutting and explanting the IOL. Dr. Nilesh, does your technique vary when you're explanting a hydrophilic versus a hydrophobic IOL, or?
Not as such, ma'am. It doesn't depend on the material because I use a serrated scissor that is from Joja, no financial interest to cut that. The only thing that I do differently, what Anurag has shown, is I go through pars plana to have an irrigation port in place so that it prevents anything to, like the flow of the fluid will keep the IOL from falling behind in case of a large PCR that is there. And I try to hold instead of the second instrument is a forceps, usually a BX forceps. With that, I hold the IOL while cutting, so it doesn't slip and also it doesn't fall behind. So cutting also becomes easier with that.
I think cutting the lens into full half is also not needed. We can even cut the lens into half and then pull it
And
out.
slide it out. Yeah.
And technique also.
Yeah.
Dr. SK, sir?
But in a hydrophilic IOL, no, you need not even cut. You can just twist it and
Twist it and take out. Yes, ma'am. If it's 3 mm, I think it is easier to take out the 3 mm.
Dr. SK, sir? In this case, the IOL was in ABF, and sometimes manipulating and pulling the IOL also can cause vitreous traction. But if you are going to do a vitrectomy, it increases the risk of IOL dropping also. So how would you avoid increasing the vitreous traction?
You have to actually, first of all, you have to stabilize the lens. You bring it to the anterior chamber and you try to remove it. And while removing also, like as Nilesh mentioned, we have to stabilize the optic using the second hand. Like your second hand instrument, it should not be like your Sinskey hook or other instruments. It should be a forceps wherein you can grip the optic of the lens and with the either a straight one scissor or even the serrated scissor, which is actually what Nilesh mentioned from Jojo. surgical. So that can be used, but the left hand, you have to hold it firmly. Then only you will not damage or the vitreous prolapse will not happen. You will maintain the chamber and you can cut it. I usually cut it full length and bring it out. In one go itself, you should go. You should not go repeatedly and cause more damage. And of course, 2.8 millimeter is sufficient to bring out a lens from the antechamber. So you remove the lens, then do a thorough anterior vitrectomy, and then place the lens of your choice.
Kamal, I wanted you to add, there's vitreous there and vitreous traction can happen. What would you do differently?
No, ma'am, here if I'm going to do a vitrectomy prior, I think the lens might drop. I think
Yes.
what you have done is correct, but the most important thing is following the patient postoperatively and examining the retinal periphery when the patient comes for the visits. Early 2 weeks and 6 weeks is really important in these cases.
Yeah, right. So on to the next speaker, Dr. Lippy.
Next speaker is Dr. Rakhi De Cruz. She is a very dynamic executive member of YOSI, and she is currently a consultant at Chaitanya Eye Hospital, Kollam. Over to you, Dr. Rakhi.
First of all, thank you, Chitra ma'am and YOSI for this opportunity. So since the theme is Catateach, I thought I'll share a small tip, a small technique which will help the budding surgeons in dealing with soft cataracts. I'm just playing my video. Am I audible and is my screen?
You're audible.
So introducing the 5:5 spin technique, which is actually a nucleus rotation technique, which can be used mainly for soft cataracts. So this idea of this technique was sparked by a great surgeon, Dr. Netta Rosatelli. I was watching one of his videos of multi-spinner carousel technique, which is used mainly in soft cataracts. This helps in preventing cheese wiring and improves the rotational control. This facilitates smooth maneuvering of the nucleus and it is very easy for the beginner surgeons to adopt. So you can see his video, he's doing a proper hydrodissection and a hydrodelineation. This step is very important in all cases before any rotation techniques. So after this, you can see the surgeon is rotating the nucleus in clockwise as well as anti-clockwise direction, a total of 16 times. This will loosen up all the epinuclear plate and the cortical matter, and the nucleus also pops up so that it can be easily aspirated just in the epinuclear mode. So from this, I adopted the 5:5 rotate technique. You people will be wondering why to waste so much time in rotating and rotating, but believe me, it takes less than 10 seconds. This should be done after a proper hydrodissection, and this will loosen up all the epinucleus and cortex, so you can save time in removing the epinucleus and cortex. Just demonstrating this technique, you can see I'm rotating 5 times clockwise and then 5 times anti-clockwise, loosening up all the cortex and the epinucleus. So from my experience, it's very useful in soft cataracts, so that you don't have to do any trenching or use any tracking or use phaco energy at all. Also very useful in very hard leathery cataracts, especially diabetic cataracts, where the cortex is very sticky and the epinuclear sheets are strongly adherent, which takes up all the time. So just demonstrating another case of a leathery hard diabetic patient's cataract. Believe me, so pardon me for the off-centration of the video, but believe me, I've done a proper hydrodissection and the fluid wave was visible, but still I was finding it difficult to rotate. I have edited few parts, but I had actually struggled with rotating. Then I understood that there is subincisional adhesion, which is preventing the rotation. So one tip here is to go through the side port and give a gentle hydrodissection in the subincisional area if your 4 o'clock and 8 o'clock hydrodissection alone is not properly cleaving up the cortex. So with this, the cortex cleaving is complete, and now you can safely proceed to the rotational technique. So after this, because this is a leathery typical diabetic cataract, it was still difficult, but I was able to rotate it 5 times clockwise and then 5 times anti-clockwise. So it effectively loosens up all the adhesions, and then proceeding with the normal phacoemulsification. You can see the layer by layer removal, the typical diabetic cataract in that. And also you can see that there is a thick epinuclear sheet, which is usually seen in this type of cataract, which usually takes up a lot of time. Sometimes it will not come up that easily, even in the epinucleus mode. So, but here, because I have done a proper rotation, you can see removing the epinucleus becomes a cakewalk. Everything comes out very easily to the probe and it takes very less time. And I have noticed that whenever I'm doing this rotational technique, whatever left, the cortex that is left will be very less, and it will be can be easily aspirated out also. You can see very less cortex is what is left out. So a message to all budding surgeons: if you're a beginner struggling with the various of PSCC type cataracts and also in diabetic cataracts, try this technique. It is very easy. And thanks for watching.
Thank you, Dr. Rakhi. I think very well demonstration of managing soft cataracts. I would like to ask Dr. Nagesh sir for his comments.
Yeah, a good technique, Dr. Raghavan. I have watched this Rosatelli videos many times. Good technique. Yeah, though I haven't tried myself on it. Works well. We should try and see. Nothing much to add in this.
Dr. Aarti ma'am.
Rakesh, I think we all know Dr. Rosatelli, how he works. I just want to find out, do you think that the impact on the zonule of this technique, has it been studied? And have you seen any post-op wobbling of the lens or anything like that?
Ma'am, I think in very brown mature cataracts in which we are considering some weak zonules and such things, I think we should not be doing this. Otherwise, mostly I have actually started doing this technique in soft cataracts only. So in those cases, I haven't found anything post-operatively. And I have then tried it in some leathery cataracts because initially I was struggling with the adherent epinuclear plates in diabetic cataracts. So in that also, I have seen that post-operatively there is no cellulopathies, nothing, no wobbling of lens or anything like that.
Okay, fine. Thank you.
Thank you, ma'am. I think we can move on to the next speaker.
Yeah, thank you so much, Lipi. I would like to call Dr. Somer Hussain to please start sharing his screen. Dr. Somer Hussain is currently working as a consultant of cataract in Bangladesh, and he will be presenting a video on meticulous planning for a cataract surgery. Dr. Somer, you can go ahead.
Thank you very much. Am I audible?
Yes, you are. Your video is visible. You can start playing.
Yeah, thank you. My topic is actually post-Rexis extension cataract surgery management. Okay. There is an Rexis extension at 2 o'clock. So I am told to manage the case. Now, as a surgeon, you can never guess what are the situations you were 30 minutes before. Like 30 minutes before, you can have a nucleus drop. Maybe you promise the patient a premium IOL. Maybe this patient is one-eyed and this is the better eye. So all these things make this complicated situation even more complicated and makes a surgeon more nervous. So, as a surgeon, what you should think and how you should prepare for this kind of cataract case, this is the point of my presentation. Okay, when I started, I begin to think what is the most important thing. The most important thing is always the cornea. If I don't damage the cornea, then if I am lucky, I can put the IOL in the bag. But if I'm not lucky, there is always a chance of secondary IOL. Second, if I know my phaco-dynamics well, then I can lower my bottle height, adjust the vacuum and aspiration flow rate, and complete this phaco in slow and smooth manner. Now, third, if I can maintain the anterior chamber stability by using gel, then I can always reduce the risk of creating another Rexis extension or reduces the risk of this already presented Rexis extension extended to the posterior capsule. And fourth, what is the decision? Should I do phaco or SICS? Now I see this nucleus is only grade 2, so I think I will go for phaco. But if it is grade 4 or black cataract, certainly I would have go for SICS. Now, first thing first, I made another cut in the capsule and completed the Rexis without creating any more damage. Second, the hydro part, I do gentle hydro. Just when the wave passed, I stopped. I didn't let the nucleus to come up. Now I made another problem here. I actually did and second hydro. This is unnecessary. Now the rotation part, I do very gentle rotation. I didn't try it too much. Now the phaco part. What should I do? Should I do 4-quadrant? Should I do modified job? Should I do stop and chop? I didn't choose 4-quadrant because I didn't want to lengthening the phaco procedure. Why not modified job? Because the rhexis is already extended. I didn't want to put any pressure over the rhexis margin. Now, why stop and chop? Because I can do better stop and chop. Now, how many pieces should we make? I think I should have made 4 pieces here. Instead, I did 6 pieces, but I should have made 4 pieces here. And during the nuclear rotation, I should have rotated the nucleus on my left hand side because the rhexis extension is on the right hand side. You were saying? Okay, I always maintain the anterior chamber stabilize and during the cortex removal. Well, should we use bimanual? Should we use coaxial? As the rhexis is extended, we should always use coaxial. Now the AWEL selection. A patient intended for monofocal plus, but as there is a chance of the AWEL to come up, so I thought patient might lose the benefit of monofocal plus. So to avoid any complication, I just put monofocal AWEL in this case and put the haptic 90-degree apart from the rhexis extension. Thank you for your patience sharing.
Thank you so much, Dr. Somir. I think you've narrated the steps very simply for a beginner to understand. Dr. Vidya ma'am, would you like to give any comments on the video as well as anything else which you feel that should be done in such a case?
Excellent video, and he has spoken about it, all about it. Here, the first step is not the force, but the chamber control. That's very important because once we lose the chamber control, that is where the problem starts. And the earliest warning sign would be a flap motility sign. That is when we should stop doing phaco. Even a conversion would also be helpful in this. But if the extension persists, try to do a damage control by doing a rhexis and then downsize the rhexis, modify phaco, use low parameters, low ego. That will definitely give you a good result. So that's important. Otherwise, it's told everything else.
Thank you, madam.
Shall we go on to the last speaker?
Yes, ma'am.
Yeah. So we have now Ruchika Jain, who's a young consultant at Isha Netralaya, Thane. And let's hear her presentation. Again, an interesting video.
Thank you, ma'am. It's a great opportunity. Good evening, everyone. Is my screen visible?
No.
No, not yet.
You should have opened your presentation before.
Yeah.
You did that?
Yeah, I have. Is it now visible?
No. Will Murugan, can you guide her?
Dr. Ruchika, just press share screen and after that, press your desktop.
Will Murugan, can you call her on phone and advise her? He's talking, I think.
Yeah, just a second. It's
Ma'am,
I have video, ma'am, so I will play it
you
now.
play it. Yeah, you play it video.
Sure.
Yeah, sure.
You can talk, yeah.
Good evening, everyone. Good evening, everyone. Myself, Dr. Ruchika Jain from Isha Netralaya, Thane.
I am presenting today management of phacomorphic glaucoma. Phacomorphic glaucoma is a neglected advanced mature cataract causing secondary angle closure glaucoma. It presents with pain, redness, shallow AC, raised IOP, not responding to anti-glaucoma drug. So the initial treatment to lower the IOP, anti-glaucoma medication, laser treatment and hyperosmotic agent can be used. Definitive treatment is cataract extraction. For flat AC, as in our case, even after the initial treatment, to reduce the positive pressure, pars plana vitrectomy can be done. A 28-year-old male came with a vision of PL positive with a history of trauma, was diagnosed with a traumatic cataract. With digitally eyeball was rocky hard, PI was attempted and oral CAI was given to lower the IOP. So let's see we went about this case. So mannitol wasn't given in this case. I made a 23 gauge token entry and did a bit core vitrectomy, constantly checking the eyeball pressure. Intracameral phenocane injected to dilate the pupil. Bag was decompressed with 27 gauze needle by aspirating some of the cortex material. Now the rhexis was completed and the soft cortex and the nuclear matter was removed by the irrigation aspiration cannula. In my opinion, this is the easiest way to manage the phacomorphic glaucoma or any cases in which back pressure is more than expected. A little core vitrectomy serves the purpose. Not a person of likeness. Thank you.
Very nice. Very nice video, Ruchika. Actually, I realized that in this last couple of hours, we have covered a big gamut of challenges in cataract surgery. Very nice. So,
Thank
Murli,
you.
I'd like to take this question. Murli, what would be the gauge, 23, 25, 27 gauge in these highly pressurized eyes? Which would you choose? And what is going to be that end point of vitreous removal?
Yeah, ma'am. Typically, let our vitreoretina surgeon do this. They usually use a 25 gauge in the inferotemporal quadrant. So when you put in a 25 gauge in the inferotemporal quadrant, vitreous usually prolapses. If it is not prolapsing, a little pressure from the opposite direction causes the vitreous to prolapse. And if you still get a dry tap, then you choose another quadrant to do the vitrectomy. So usually you cut out any prolapsing vitreous and put the plug in. And after that, you try to inject. The vitreoretina surgeon pushes some air bubble into the anterior chamber. If the air bubble is going in fine, that is the end point, and cataract surgery should be expedited within 1 hour of doing this decompressive vitrectomy. So usually we operate between theaters. That is, the vitreoretina surgeon does the decompressive vitrectomy and sends the case across to me, and it is on me to do it in an hour's time. So the end point is, once you cut out all the vitreous, the globe becomes a little soft, and you should be able to easily inject an air bubble into the anterior chamber, and the anterior chamber should sufficiently deepen. So that is the end point. If you're getting a fundus view, if it is not let us say a hypermature or a mature cataract, you're getting a fundus view, then I guess a core vitrectomy can be done under direct view, and it should be the end point should be a soft globe and with capability to deepen the anterior chamber with an air bubble.
Very good. Wonderful. Excellent. Sonal, do you think you would even think of axial length size when you are stuck with a phacomorphic glaucoma? Would that matter at all?
Sorry, ma'am. Could you please repeat your question?
Would you be concerned to know about the axial length also? How large or how small would anything matter to you in these phacomorphic glaucoma eyes?
Yes, ma'am, axial length does matter, and it is also very important to distinguish the fact that this is a traumatic cataract, which is being, it's a very rare instance in which you can label a traumatic cataract as a phacomorphic. And phacomorphic picture is not linked directly to trauma. First point that I want to point out over here. Second thing that I want to also say that I didn't understand why was IV mannitol skipped in the beginning. I think that is imperative to be given instead of opting for an invasive thing like entering the vitreous cavity.
Yes.
And yes, axial length is very important because everything is, really distended in such an eye. So maybe, a table check after a bit of mannitol may be required to just take the, axial length again after mannitol and after the pressure reduces significantly. That cannot be done if we are opting for a vitrectomy approach.
Yeah, it's also now, if these are smaller eyes, a little microphthalmic, then you need to place this cannula in the pars plana region. So sometimes in these smaller eyes, you are not sure whether the pars plana, where it is. It could be a little anterior also. So it makes sense. Again, sometimes this is in a microphthalmic eye, would you, Murli, think of sclerostomy, or would you straight away do what was done? Murli, please, why don't you keep yourself unmuted?
Yes, ma'am. Yes, ma'am.
Sir is saying that the patient was contraindicated for mannitol.
No, I mean the indication for decompressive vitrectomy generally in these cases is after maximum permissible medical therapy. If the pressure is not coming below 30 and the anterior chamber is still remaining shallow, so that you know that a paracentesis is not going to help. It is only going to create more trouble by causing an iris prolapse. Only in those cases a decompressive vitrectomy is indicated. So otherwise, I think your maximum medical therapy in many cases you are able to get away with that. So if the pressure falls below 30, even if the anterior chamber is shallow, you should be able to inject some, paracentesis could help you with that. But what she mentioned was the anterior chamber was nearly flat. And I didn't pick up the mannitol part, but I presume that all of us would attempt maximum medical therapy permissible. Like if the patient has renal or cardiac contraindications, you may not be able to give glycerin or mannitol. A poorly controlled diabetic may not be able to give glycerin and mannitol. So in those cases, yes, I mean, if the pressure is not dropping below 30, anterior chamber is too shallow for your comfort, and it is a clinical judgment that doing a paracentesis is not going to help. In those cases, a decompressive vitrectomy can be tried as a safe alternative. Second is, in case you start, of course, this is not for nanophthalmic eyes, definitely. So, nanophthalmic eyes doing all these maneuvers is quite dangerous. So, we would have done an immersion and an axial length measurement as a priori. But even on table, if you find that you are taking up a lens-induced or a acute angle closure attack glaucoma, which is not just coming under control, so and you are not able to proceed, I think requesting a vitreoretinal surgeon for a limited vitrectomy really smoothens out the whole procedure.
Yes. Very wonderfully summarized. It was a tough topic, and I'm glad that between Sonal and Murli, they covered all parts of the questions. So, Dr. Anujit, you go on to the audience poll?
Yes, ma'am. Thank you. Thank you so much. Manjula, ma'am, are you there?
Yes, doctor.
Ma'am, can we have the audience poll?
Sure, doctor.
So we've had almost 17 videos today, and the judges have entered their marks, and we will be calculating their marks. And in the meantime, we'll be having a short audience poll for all of us. So there will be an audience poll winner. All the participants have also been told that to gather in their audience for polling. And while Lippy does the honors of calculating the marks, we've had 16 people who have answered. I think we've had 100% answering, 22, 23. Right. Manjula ma'am, has everyone polled? Can you
No,
see it
doctor.
from your back end, ma'am?
No, doctor. It's going on still.
It's going on. Right. So while the audience poll goes on, I would just like one remark from all the judges on what they felt regarding the videos. We will start with Sonal ma'am, and then move on.
Actually, I'm not able to figure out where the poll has gone. Suddenly there was a QR code and then that has disappeared.
I would like to say that before the judges and everybody said that this was an amazing 2 hours. I mean, irrespective of who becomes the winner, to me, all of you are winners. Each of you had a superb teaching pearl and different innovative ways of putting across what you did. And for all this whole thing to happen so methodically, I would give full credit to Sonal and Lipi. They were so particular about the sequencing and timing and whom to put. And I was traveling all the time. I thought we could have just done it, but we might have taken an extra 10 minutes. If we finished the way we did, it's because one, all the videos were exactly 4 minutes and all of you did so wonderfully. And all these young leaders of YOSI ensured that it was a smooth affair. Not to say that Tamil and Murli and Vidya and Nagesh and Shrish, all of them were also wonderful in coming out with the most beautiful discussions and answers.
Thank you. Thank you so much, ma'am. Thank you for guiding us through this webinar. I think there was a lot of hand-holding from you, which we really appreciate
No,
as
you guys
YOSI.
don't need hand-holding. You all are very good. I realized that this time. I was truly proud of you all. You all don't
Thank
need
you.
hand-holding.
Thank you so much, ma'am. For those who are looking for the audience poll, Nilesh sir has posted a QR code, or else on your Zoom, you can click on the word more and click on polls and quizzes, and the poll will come up in front of you. Manjula ma'am,
Yes, doctor.
can we stop the poll?
Yes, doctor. Stop, doctor.
Yes, thank you so much. So, Dr. Lipi, are you there?
Yes, I'm there. So can we have the results of the audience poll?
Can
Yes.
we close the screen?
We'll share it now, doctor.
Okay.
So we have the judges' scores also compiled.
Manjula ma'am, are you sharing the results?
1 second, doctor will share.
Sure.
Yes, all the judges and the expert panel, anybody, you have any comment to add? All of you, any of you?
Ma'am, I think the best part of the webinar was that the participants took teaching to a different level. That means they did not just stick to their surgeries, they came up with other options of teaching, especially the first few videos regarding alternate ways of teaching stop and chop and other surgeries. I think that was one highlight which we really enjoyed. It opens our eyes out. And I think every aspect of cataract surgery was somehow covered. And in the spirit of teaching, a lot of effort was made in teaching and making sure the audience does understand. For someone who's watching this video in retrospect, I think it will be very beneficial.
Actually, it's not just one video. All 17 videos should be watched.
Yes,
Somebody
exactly.
give it 2 hours, yeah.
I also want to, really compliment Chitra ma'am for the meticulous preparation that she has done for this particular webinar. So she has really, watched all these videos in depth and prepared so many questions and seen so many, subtle points that may be missed if you end up seeing them directly over here. So that is something to really learn that from her with the amount of travel that she's doing right now for the campaign and everything, and still she's found so much time and devoted herself to this. So it was really a teaching moment and leadership quality as well. So hats off to you, ma'am, for giving this partnership opportunity to YOSI and for honing the skills of so many young ophthalmologists via this video competition, as well as you yourself as an example for us.
Yeah, we should do one more in Jan. Don't you think so, Sonal?
As you say, ma'am.
Yeah, sure. I think this has been a real eye-opener. We'll discuss about it.
And I think also the quality of videos, like the video editing, were very to the point.
Yeah.
So like it was Catateach, so they were sticking to one point. It was not like a fast forwarded entire Catateach video, and they were just getting this point to be done. So that
Yeah.
is also very good thing to learn for all the future speakers
Yeah.
as well. But
Yeah.
how to impactfully edit that video.
Yes, yes. True, very true. This all the pearls which they wanted to say was said so well, whether it was recorded or those who had to talk last minute. I mean, sometimes it's even better if you all talk. You guys don't even have to record it. You all are all very capable.
And I believe that Dr. Lippy deserves a real round of applause. She
Round of
has
applause.
worked very hard for this
Yeah,
particular
truly.
competition,
Yes,
and
very hard.
without it, this final form would not have been possible, I should
Yeah,
say.
yeah, truly. And she was always smiling and she was persistent. She will see to what she had, thought about this whole program and ensure that we all obeyed. I did disobey at times, but that's okay.
And for me, what was standing out was that instead of a cataract competition, everybody was sticking to the theme that Catateach. So they were emphasizing on those teaching points. In fact, what I've seen in a lot of cataract-related video competitions, it is like one after the other show off at times that I can do. I'm not trying to.
I agree with you. Yeah.
But sometimes, it gets that, I can do this. What can you do? And even in the complication, see, I've done this business and I've handled it here. It was more focused on teaching, which is what is appropriate for young ophthalmologists. In fact, the most basic video of the workup of mature cataract, even that was such a brief and to the point video for a young ophthalmologist. These days, the attention span is also less. People want everything in nugget-sized companions. So for that kind of generation, I think these videos are also very good, in which they're teaching not just about the surgery but the entire pre-operative workup. So really hats off to that particular video as well.
Yeah.
Ma'am, we are ready with the results.
Yes.
So this in terms of audience poll results, I'll just share it. It's in front of everyone's screen, but I'll just mention it for everyone. In the second runner-up is Dr. Anurag. The first runner-up is Dr. Gina. And the audience poll or the audience choice winner is Dr. John Davis Akara. Congratulations so much, sir.
Congratulations to all of you. Wonderful. Wonderful.
I would request Chitra ma'am to just announce the results.
Yeah. But
it's not, the screen is not moving actually.
Yeah.
So
Yeah, we can see the runner-up.
So the runner-up audience choice is Dr.
Yeah.
Jeemay Hassan.
Yeah.
I request Chitra ma'am to announce the next winner.
But where is it visible?
Ma'am, she's shared her screen. Lippy has shared her screen.
Where has she shared it? It's not come on my message. It's
No,
on
ma'am. On the screen.
On the screen, ma'am.
She has shared her screen, ma'am.
Yeah, who has come first in this?
So runner-up audience choice goes to Dr. Jeemay Hassan.
Yeah. No, I think okay, 1 minute. Yeah. Runner-up audience choice goes to the winner, Jeemay Hassan. So congratulations, Dr. Jeemay Hassan, for being the audience choice winner.
So that was the runner-up, ma'am. Next is audience choice winner.
Yeah. The audience choice winner goes to John Davis Akara. Yes, John, I think you will never accept the runners-up in your life. You got been spoiled by all of us. You always seem to become the winner. But yes, you had that extra thing, which wonderful. Congratulations. Proud of you always.
So the judges runner-up award goes to.
Oh, very nice. The judges runners-up award goes to you, Raki. Yes, but only thing, how you decided that 5 is the golden number and why not just 3? You've tried the 3 and the 5 and you decided 5 works better, huh?
Yes, ma'am. I tried the 3, but it was not working with all cases. So finally, I moved to 5.
5. Anyway,
I've been
congratulations.
doing 3. Now I'll try your 5 also.
Congratulations.
So the Best Teaching Pearl Award goes to
Oh, very nice. Yes. Yes, Shantanu, that was a wonderful presentation of yours. At such a young age, you had the intelligence to point out every important thing about that BX thing which you showed, no? That was
Thank you.
wonderful.
Thank you.
So
Thank you so
congratulations,
much.
Dr. Shantanu. Like, I think all the judging has been superb. Like, all of us thought alike. But to me, actually, having said it all, I felt that a prize should be given to all of you. All of you were wonderful. So congratulations to the winners and congratulations to all the participants. So concluding remarks anybody wants to give? I would say that I enjoyed these 2 hours most optimally with all of you. And I look forward to coming back with you all and coming with different innovative ways of having teaching stretched across to the entire AIOS. So hip hip hooray to all of you.
Thank you, ma'am.
Thank you so much,
Thank
ma'am.
you.
Thanks a lot, ma'am.
Congratulations to all the participants. Thank you, Chitra ma'am and Sonal ma'am, for bringing this session together. Thanks to all the judges, panelists, and moderators, and all the participants and audience for joining us. So
Yeah.
we would like to have a group photo.
Yeah.
Please switch on your videos, everyone.
Switch on your videos. Yes.
Manjula ji, can you take a picture? Screenshot?
Sure, doctor.
And one with the YOSI sign.
I've taken a photo.
Thank you.
Right.
Thank you. Thank you. Thank you so much. Go have a great dinner and look forward to another interesting meeting with you all. Bye-bye. Good night.
Thank you, ma'am. Good night.
Good night, ma'am. Good night.
Good night,
Bye-bye.
ma'am. Thank you once again.
Thank you.
Good night.
Good night, everyone. Good night, ma'am. Thank you. Thank you.